Good afternoon, everyone, and a very warm welcome to you all. Thanks for joining us today for this very important session delivered in collaboration with the Legs Matter campaign and the Sigmaris Medical Online Hub. My name's Annie Clothier. I'm a vascular clinical nurse specialist and I'm co-chair of the Legs Matter campaign. And I am delighted to be moderating today's discussion alongside our expert panellists, Sarah Bradbury and Kath Kavanagh. Welcome, ladies.
Okay.
Today's session sits at the heart of what Legs Matter stands for, preventing avoidable harm related to lower limb conditions. Across all care settings, we continue to see delays in diagnosis, missed opportunities for early intervention, and patients presenting later with complications that could and should have been prevented. We know the consequences, we all do: progression to chronic edema, worsening venous disease, development of leg ulceration, and those repeated episodes of cellulitis, and ultimately the loss of mobility and independence for these patients. They're not just clinical challenges, they significantly impact our patients' quality of life and place a considerable pressure on already overstretched services, and we know how overstretched the NHS is at the moment. But the key message today is a hopeful one. Most of this harm is avoidable, and as our slogan says this year, it doesn't have to be this way. So our focus today is on shifting that dial from reactive treatment to proactive prevention. And we'll be exploring some key areas such as early identification, recognising those signs of lower limb disease before complications develop, timely intervention, ensuring that these patients receive the right care at the first time, and avoiding those delays in inappropriate treatments as well. Prevention of complications, particularly reducing rates of cellulitis, ulceration, and obviously avoidable hospital admissions, and also empowering self-care, giving the knowledge and confidence to manage their conditions earlier, and importantly, system-wide responsibilities, because prevention is not owned by one profession or setting. It requires a coordinated approach from professions across primary care, community services, and secondary care. This session is designed to be practical, so our aim is to equip you with clear, actionable strategies that you can take back to your services, helping you to intervene earlier, act more confidently, and ultimately deliver better outcomes for your patients. At the centre of the conversation is one critical principle. Prevention starts with recognising risk early and acting on it. As the Legs Matter slogan says, and I've mentioned it earlier, it doesn't have to be this way. With the right knowledge, clear pathways, and timely use of compression, we can prevent escalation and significantly reduce that avoidable harm. I'm really looking forward to the discussions ahead and to hearing from our expert panellists who bring a wealth of expertise with them and insight into this area. And we want this to be as an interactive session as possible, so please post your questions and we'll endeavour to answer them as we're going along. Thank you again for joining us, so we'll get started. So Sarah, can I ask you first please to introduce yourself?
Yes, of course. Hello, everybody. I'm Sarah Bradbury. I'm a clinical nurse specialist in tissue viability at Cwmtach Morgannwg University Health Board in South Wales. I'm also a trustee of the Society of Tissue Viability, who support the Legs Matter campaign. And I've been working in wound care for about 22 years now, so lots of experience with lower limb conditions.
Lovely, thank you. And Kath, could you introduce yourself, please?
Hi, good afternoon, everybody. So my name's Kath Kavanagh, and I am a practice nurse. And I'm a practice nurse in York, a big GP surgery. And I am not a specialist. I'm a practice nurse. And so this is what I do every day I'm working. So I'm here really because we've set up our own specialist lower limb and wound clinics and look after all our patients ourselves. We don't have any services that we can refer into. We have no lymphedema services or anything like that. We have amazing TVNs to us locally who try to support us. But other than that, we don't have any way to refer into a local service. So we just do our best. And we've seen a lot of improvements by running our own clinics in-house. And so that's my experience, really. And so that's where I'll be talking from today.
Brilliant. Thank you. Well, this is very exciting for me, ladies. I'm really, really pleased to be doing this with you. So let's start off where we think the harm happens in our current pathways. How are we missing these opportunities to deal with issues at an earlier presentation? Anybody fancy taking that first, or shall I direct it?
I think I think we're still struggling with a general lack of knowledge and awareness around identification and assessment of lower limb conditions. And until we get that bit right, it's very difficult to then go on and improve our referral pathways and to look at early intervention of treatment such as compression therapy. Because we have to recognise the harm before obviously we can, or the potential for harm, before we can intervene. So I still think that knowledge and education is still at the core of addressing this problem, and where patients are coming to harm early on because they're being missed. These early signs aren't being recognised.
Yeah, I mean, from my experience, I can certainly concur that there is a lot of late presentation to specialist services. And I know we talked last night about chronic venous disease and the impact that has by not starting intervention early. And I think that this is still a massive problem. I don't know what you feel about that, Kath.
So I think you're both completely right. And I think it's a lack of confidence in people, in healthcare professionals who are seeing patients first line. And they might see somebody in the surgery with a swollen limb or bilateral swollen limbs or venous changes that they maybe can identify, but they don't quite have the confidence to do that. And then think, well, they're okay at the minute, and so I won't do anything about it. And it's lack of confidence and lack of education, really. And I think it's not just educating the nursing teams that are seeing patients. It's also educating a lot of our medical colleagues who are in primary care and don't have that confidence to decide what to do with the patient, or maybe there is no local services. But in our situation, by actually sort of providing a service locally within our own surgery, hopefully we are dealing with things sooner. And it's simple things as well, like just saying, okay, well, this patient needs some compression hosiery. And here I have some in the cupboard, and I'm going to put that on you straight away. But it's having the confidence to do that. And that's very difficult to achieve, isn't it? When you're in, for example, in our surgery, when you're a practice nurse, you're seeing multiple different kinds of patients all the time. To build up that education and build up that confidence, it's tricky, actually. And that's why things like this are so useful, to see that we're all trying to deal with the same situations, and simple ways of doing that. And also, a lot of the time, I use a lot of our industry partners. They are invaluable in primary care. They really, really are. But it's finding what's good for you locally. But again, I think you're right. You come back to education and also just experience and just feeling you can get on and do it.
I'm interested to know, I mean, Sarah, you've got a wealth of experience in education in your background. Is it as simple as just providing education for people? Do they go back and change their practice then? I'm just wondering if it's just as simple as that, or is this more of a systemic thing?
No, I don't think it is as simple as that. And we have to think about what the barriers are, to delivering, but also implementing the education that we provide. And going back, picking up just on something that Kath just said then, I think we can, as specialists, sometimes we are so focused on it. This is what we do every day. And we have to remember that for the generalists out there, this is only a part of what they do. And often for primary care and for maybe community nursing services, it's a large part of what they do. We've got to remember that it's not the only thing they do like we do. And I think it's about picking up on the people who have got a passion for wound care and utilising them in these services to be able to educate within their teams, and also to just sort of make people excited about wounds. You've got to have that engagement. You've got to be able to connect with people, for them not to be able to go, oh, okay, this is just something that I've got to sit through and tick box, and then but I'm not going to actually change my practice when I take it away. So I think it is about really engaging with people. And again, this is why Legs Matter is so important. It's about that raising awareness. I think, if you said to maybe a generalist clinician, a district nurse, so actually you're doing your patients harm because you're not implementing compression, they'd be really surprised by that because they've never thought about it in that context, that not delivering good wound management and compression therapy is a harm in the same way that not giving your patient a medication is a harm. And yet you recognize that straight away, but we don't recognize it when it comes to our patients with lower limb conditions. So, again, it's providing that context as well, isn't it?
Yeah.
So also, sorry to just interrupt there as well and pick up again, Sarah, what you've just said. It's not just about educating all the healthcare professionals, it's about educating the general public as well. Because if patients know what should be available and what is potentially available to them, then they will come and ask for it. And we know that with lots of other different conditions and, and improvements in general healthcare and multiple chronic conditions that patients have these days, patients are more and more educated themselves. And we've gone past the days where we pull a face if a patient has been Googling what to do about something, because really we should be welcoming the fact that they're going away and looking about it. And if we get more of these kinds of things like Legs Matter out there in the sort of the general internet rather than our specialist things, then our patients will be more empowered. And then that brings us then to them being able to self-manage with support, because I believe so strongly in self-management as much as possible, but it's not go away and do it. No. It's go away and do it, but with support from me, because you can come back anytime you like. But we need to empower patients as well. And the lymphedema websites and things that they're really doing so many amazing things in that kind of era now. But it's not just about educating healthcare professionals, I don't think.
No, I think you're right. And patients are certainly more empowered and they're more engaged now as well than they used to be. The times have gone where it was, the nurse told me to do this or the doctor said I have to do this. They want to know. And with the advent of social media and the internet, the information is more accessible for them. So they often, as you probably all experience, they come to clinic and they'll ask you about certain treatments, things like this, or somebody up the road said that, I should ask you about this. And they are more engaged in their care than they used to be. I definitely agree with that. Absolutely. But social media certainly is a powerful tool for those patients. And I know we did our webinar last night and some of the patients came in this morning and said, I watched you on Facebook last night. And I liked what you said, things like that. And they're watching and they're listening. So it is definitely very powerful. So I'm going to ask now about how we get it right the first time we see our patients and making sure that we've got that early recognition and promoting confidence then in decision making. So I'm going to ask you, Kath, what does right care look like at your first contact with a patient?
So right care for us, in terms of there's a number of different scenarios. So we can think about patients who might present with an ulceration the first time, and that's the first time that we've seen them. But they might have been in the system for a couple of weeks even. They've knocked their leg, and then they've had some antibiotics, and then maybe a clinician has given them some more antibiotics, and that's what we're trying to get away from. And so we're trying to get towards much more like this is a lower limb injury. And so we know that we're going to treat if there's an infection if they've seen an urgent care member of staff, then we're going to do that. But we're also going to liaise with our nursing team. And so what we would be then doing is straight away thinking, right, we're treating the wound, obviously, but then immediately thinking, can we get them in class 1 compression straight away? And we do that by having well-educated staff who are confident to look for red flags and who are confident to then say, right, we've got class 1 or liner hosiery. Lots of different companies out there have different levels of compression, but if we're talking about that lower end of compression, then a liner or class 1, and we have that in the cupboard. And by using ordering systems that lots of us have available to us, then we don't have to get something on prescription. We don't have to wait. We can get something implemented straight away. And for us, a lot of the time, it's just about being able to implement almost immediately. Because if we can do that, then the patient straight away is going away thinking, okay, right, I'm on a pathway now. I've had some education. I know what I'm doing. Most of these patients, we don't see them, 3 times a week and all these kinds of things that we used to. We will follow them up, but they are self-caring for their wounds, and they've got their hosiery, and then we follow them up with that. So it's about having things that in our cupboard that we can do immediately, but it's having the knowledge and the confidence to do that as well, to think, I know that this is the right thing to be doing. If we're talking about patients with lower limb edema, which and maybe don't have any ulceration, we liaise really closely with our heart failure specialist nurses. And in the same way that one of my specialist roles is doing wound and lower limb care, some of our nurses within the practice, one of their specialist roles is doing heart failure care. So we liaise really closely with them. They send them to us straight away. So if they see a patient with a concern about swollen legs, then they're getting us involved straight away, so that we can Doppler them if needed, and we can then get appropriate hosiery on them sooner rather than later. And by sooner rather than later, then obviously we're avoiding long-term consequences, including ulceration and that kind of thing. And also, chronic skin changes and this kind of thing. So it's just about immediate care. What can we do fairly promptly? It's not always that easy, is it?
What about those clinicians then that are not necessarily that confident? So I'm going to ask Sarah, what do you think stops clinicians initiating compression at an early stage? What are the barriers, do you think?
I think ultimately fear is still at the forefront of it. And we're working really hard to dispel the myths and to reduce the fear around compression therapy. But it is historical and it's ritualized, and we are having to fight that battle still at the moment. So, and it's changing that messaging around, the fear of instigating compression is that you might do your patients harm, rather than thinking, actually, I'm doing them harm by not instigating that compression. And I think at the core of and the forefront of instigation of compression therapy is also around confident assessment of that limb. If we can improve people's confidence in what they see, what they hear the patient telling us, what they feel when they're examining that limb, if we can get that confident assessment in place, when I'm teaching, I always say, that people want to rush in and do a Doppler assessment, and I'm like, right, take a step back, because you can actually form probably a very good opinion in your head just using good assessment skills of whether or not that patient's got significant peripheral arterial disease, whether they've got chronic venous insufficiency, and whether or not they're suitable for compression therapy. So I think really teaching people about looking for those signs and symptoms, looking for skin changes, looking for varicosities, for edema, looking for, those classic signs of arterial disease. And then that can remove the fear of doing harm. I think, just as an add-on to what Kath was saying as well, what is right care at first contact, I think it has to be about personalised care planning for that patient as well. And it's taking every opportunity to have that discussion with your patient. You're exploring options with them. You know, sometimes maybe we don't explore options with them. We look at the limb and go, right, okay, this is the most appropriate compression therapy for you. And so this is what we're going to recommend. When actually, you know, they might be better in a wrap rather than some hosiery that they really have struggled with donning and doffing. You know, so we're looking to get to know your patient better. Looking at what their needs are, what they're capable of applying, you know, so we're promoting that self-management wherever possible. What are their priorities rather than what our priorities are? I'm thinking about maybe what social support they've got, you know, have they got someone at home to help them put their compression therapy on? And then that will then help us, like I say, to personalise that care plan for that patient with the best type of compression for them. That's hopefully then going to improve their engagement going forward.
Yeah.
I always say as well, sorry to interrupt there, Annie, and absolutely, Sarah, that I always say to the patients, if we're instituting compression, then often it's a journey. And just because I've put something on you today doesn't mean that you can't come back next time and go, do you know what, I didn't like that and it didn't work. And I think you're absolutely right. It's about building up that relationship with them. And that is the joy of being like a frontline kind of health care professional or a practice nurse or whatever area you work in. You're the person who's seeing these patients on a regular basis, and you can build up that relationship with them. And then, as Sarah's just said, you know, you can then develop a pathway for them that is individual to them and may not be suitable for somebody else, but you can work it through it together.
I agree, definitely. And I think that it's not a one size fits all. And I often get referrals, patient won't tolerate compression, won't comply, but is that the right one? And, you know, what have you tried? So this is all useful information, definitely. And I totally agree with you, Sarah, that there is a fear factor. I probably get slated for this, but if I could get rid of ABPIs, then I would, because I think that is such a massive barrier for people. And you get 90% of your diagnosis from just talking to your patient. And that's the thing that will aid you the most in your diagnosis. And I think we put too much emphasis on the numbers.
Yes.
And they're just numbers.
Yeah. And we're not good at interpreting those numbers very well.
No. And I know that's easy for us to say because that's what we do every day. And it's having the confidence to make that decision and say, well, actually, no, there's other things that would enlighten me to the fact that this is just purely venous. I'm not going to worry so much about the numbers. So, yeah, I think there's a lot about reducing the fear factor and tailor-making your compression to your patient as well, definitely. So we've talked a little bit about initiated compression early as well. Obviously, we have lots of pathways in place. And do you think that these pathways are enabling or delaying care? Controversial question.
A big one, isn't that? I think a well-designed pathway that is clinically relevant and easy to understand is a good pathway. And I like those pathways. And I think, you know, obviously we've had so much focus from the National Wound Care Strategy Programme in terms of pathways. And within Wales, as you and I know, Annie, you know, we've got our standards for leg ulcer care in Wales as well. And I think that a pathway, when it's used appropriately, can help to instill that confidence in people who maybe are a little bit fearful of or lack confidence in their assessment skills, are fearful of instigating compression. And I think, you know, if you talk to a lot of generalist clinicians now, I think, you know, many of them have heard of the National Wound Care Strategy. They know there's guidelines out there for it. I think there is more awareness of early instigation of mild compression in the absence of red flags. I think that is happening slowly, you know, and we still need to work really hard to spread that message. But I think, I think there's a role for a pathway, but we also, you know, obviously with any pathway, you've got to still have your own independent clinical decision making and your own judgment, isn't it? You know, so there still needs to be that underpinning knowledge. But I do think they are quite a useful way of improving confidence with that decision making.
Yeah, I was just going to say exactly the same, Sarah, that it gives you that little bit of confidence to think, okay, I can sort of work out what I might do here, but now I'm going to look at the pathway, and that's going to reassure me. And also, so for example, if you're, a nurse in a practice or in the community, and then you can justify your decision making to someone more senior than you, or if you've got to refer a patient on, you can think, right, I've already followed that pathway, I've already done those early stages, and I've done that right. And it does give everyone a lot of confidence, I think. And we're in all of the areas that we work in, certainly in general practice. And I'm sorry to keep coming back to that, because I know everybody works in lots of different kinds of areas, but we're all used to different kinds of pathways these days. We're titrating medications, we're doing all kinds of different things, and we're used to using pathways. So I think in the majority of cases, people find them really reassuring as long as they understand them.
Yeah. Definitely.
And that's part of the thing, isn't it? Is that maybe people haven't had education on the pathway and why we make certain decisions. And it's a little bit like you say, you do an ABPI and the result is not what you want it to be, or is slightly outside the boundaries of the numbers. And then what do you do then? So it's knowing what to do when things are not quite right and don't quite follow the pathway limitations, really, isn't it?
Yeah, a guideline is a guideline. It's just that a guide.
Yeah.
Yeah, definitely. I know. So I'm going to ask now about prevention in practice then. And I'd really like Kath to share a brilliant work that she's undertaken in her area, because you're quite unique, really, up there in York.
We try. So to just share a little bit about it is that I don't know, I did a presentation about it Wound Care Today this year as well. And what happened here is that we were seeing multiple patients in our normal clinics with wounds, and then COVID came along, and we had a huge cohort of patients who still needed to be seen. And we weren't running normal clinics, and so we had to set up special clinics that these patients could still come in, because the district nursing teams, the community services were completely overwhelmed. We couldn't add to that. So what we did was we put in just separate wound clinics in a GP practice. We're a very large practice. We're 44,000 patients with 6 different sites. So just out of a few of our sites, we started running these separate wound care clinics, which are built differently to the other clinics in the surgery. The template's different, the appointments are longer, and it gave time at that point for people to be looked after well, and also not have an overlap with patients. Following COVID, we just carried on with that. We have very, very supportive management, which we're very fortunate to have. And so we've carried on doing that. And that gives us the basis for how we run our clinics now. And we have clinics twice a week, and they are part of very much our normal clinics in the primary care situation. But they are kept separate. We have different timings. And we see huge, all wounds, any kinds of wounds, abdominal wounds, post-op wounds, leg ulcers, anything at all. But we've now introduced seeing a lot of lower limb care as well. If GPs require an ABPI for diagnostic purposes, we do all that kind of work as well. And as I intimated before, we don't have anywhere to refer to. We have no lymphedema service. We have no leg ulcer service in our area at all. And nowhere locally in North Yorkshire at all. So we're just doing our best in primary care. And as I've said before, I'm not a specialist, but I like to bang the drum for the fact that as a generalist in primary care, in my situation, we can still provide really good care. We can still do all of their immediate care very, very well. And in fact, better than some places, because we're there at the beginning. And sometimes we see that as like, oh, well, we didn't heal this, we didn't do that. But in fact, we've avoided having all of those problems in the first place. We try to treat the patient as a whole person as well. We're looking at all of their multiple comorbidities. We are liaising with our other specialist nurses within the surgery, and all working together as it's a great team. It's a really good team of people who don't just do lower limb and wound care. They do all of their other jobs as well. As you suggested before, we are generalists and we are dealing with a lot of different things. And this is one of our specialist arms. It's been very successul. We are increasingly seeing patients saying that, I was told by the GP that you'd sort my legs out. So this is great. That patients are seeing our other colleagues in different situations and then being suggested that they come and see us. We do our best to treat them as an individual and look at everything that is going on in their lives to try and improve the problem that they've presented with, whether that be a wound or edema or whatever. And it's possible to do that in primary care. And in fact, it's the perfect place to do it.
It sounds amazing, and I think I might have to move to Yorkshire.
It's nice.
How do you find, though, with funding? Because I know I've spoken to some people down in the south, and within their GP practices, they've stopped providing lower limb and wound care. And how have you been so lucky?
So how it works in our area is that wound care is an enhanced service. So GP practices in general, and I don't know how this works in Wales and Scotland and our other devolved areas, but in England, that mostly we are obliged to provide certain level of wound care, post-op care, for example, this kind of thing, removal of sutures, and that is part of our general practice contract. But to provide other services, for example, leg ulcers and that kind of thing, then it's an enhanced service. And so the GP practice will need to sign up for that. Now, we had never left that. Lots of GP surgeries in our area did leave offering that as an enhanced service. But we never did. And that was for a variety of reasons at the time, including patient desire, really, that they didn't have to go elsewhere. At that point, many years ago, we did have a local leg ulcer clinic that was on offer. But these things, the district nurses are gradually working harder and harder, aren't they, in community care. So we carried on providing the enhanced service, and we always made sure for a number of years that we were claiming the maximum that was available to us. And then that became obvious to us that this was a good thing to be doing for our patients. But with GP practices, and sadly, a lot of it always comes back to the funding, as you've just said. And it's about making money for the practice as well, so that the practice can continue offering those services. So we've always maximised the amount that we could earn in the enhanced service, and that made it easier to then continue to provide the nurses to actually do these clinics, because it's obvious that the money that's coming in to do that. And then it's about making things easier in other ways. So, for example, we've gone to an ordering service. So there's lots of different ordering services out there, isn't there? We have ONPOS in our area, but by having things in the cupboard, and then again, that's funded from a different part of the ICB. And I think it's all about proving your worth a little bit as well. So what we aren't doing yet, which we want to do, is to get better data. And I think if you're in any area, whatever area in the world, or whether you're in primary care or a specialist service, it's all about proving what you're doing, and that can be as simple as actually giving your patients feedback forms and getting them to give you feedback, because that's been a really big thing for us, is that we've always every year given for about a month at a time, give out feedback forms to our patients, and any service loves that, don't they? And any management loves that as well. Positive feedback from patients and helpful, ideas as well. So, if money's an issue, then they love some positive feedback. I would always go for that.
Yeah, definitely. And so I'm just wondering now, between the three of us, what do we think is the best way to identify these patients at an earlier stage that are obviously at risk of developing ulceration and deteriorating? How do we pick them up? I mean, is that an issue for patients that present visiting their GP practice? How do we get them at this early stage, other than trying to raise awareness? I mean, obviously, Sarah and I both work in specialist services, so we're more likely to see people at the later stage or when people are running into difficulty. So
I think very much. So somebody's actually put a comment on here as we're going along, which is a really, really key one. Every patient has got a GP or a nurse.
Yeah.
And for whatever reason, and now that might be a specialist nurse, they may be going to the hospital because they have a cancer, or they may have other orthopedic problem or something different. But everybody who is actually coming already into contact with healthcare does have a doctor or a nurse. And so it's educating all those people as well, isn't it? That actually has somebody got a swollen leg? Have they got venous disease? Oh, well, I'm not really sure, but I know somebody who will work that out. I know someone who will know. And that's part of what I've been doing, really. And everybody knows, you can see behind me, I go on about legs matter, and it's true, really. Legs and wings really do matter.
They do.
And so everybody knows that, but by having a key person, by someone, it's like you were saying before, somebody with enthusiasm, somebody who it really, this is, I really care about this.
Yeah.
And we have, in the same way, we have nurses who are just as enthusiastic about other aspects of primary care. So this is my thing. Everybody knows that if they're not sure, they can drop me a message, they can drop me an email, and we can all do that, can't we? So in every aspect of everywhere that we work, you can have somebody who is your key person, who's always bringing it, who's always highlighting the situation, and always somebody who can be referred to or asked about something. And then these patients, they start coming your way, and they keep coming your way. But those are people who are already in the healthcare system. What about people who are not in the healthcare system? And so I think particularly a large proportion of our population that we will be talking about here, our cohort, are elderly, aren't they? And they come into contact with carers. And so that's another big thing that I have, is that, about educating carers about understanding, so that they can say, oh, I think you should ask your GP about that, so that then they can, just all they're asking them to do is to push on into a different direction. So it's tricky, isn't it? But I think a lot of it is patient education as well, and about people knowing that you don't need to be sat at home with your swollen legs.
No.
We've got all these signs up saying it doesn't have to be this way. It doesn't have to be this way. And that people think that it's insolvable, and they have ideas in their head about their mother who had leg ulcers their whole life, and they never healed. And, you've got a leg ulcer. Elsie's got a leg ulcer, and it'll never heal. Yes, yeah, we can get it to heal. And if we're certainly going to give it a good try. And these things are not insolvable. And it doesn't have to be this way, does it? It doesn't.
Getting these patients the right place to the right time.
Yeah.
A TV campaign. If we can have a TV campaign about legs, but the problem is I think it's just not sexy, and that's why it doesn't draw the attention that other conditions do, and that's probably why we don't get as much
But would it,
information
I'm
out
sure
there.
somebody on EastEnders or
That's what we need. Someone with a leg ulcer
should
or an
have a leg ulcer.
amputation, so that you can spread the message out there about what is happening and how do these people get into this unfortunate situation. But it's not sexy.
No.
That's
You know,
that's my thoughts on it.
to use an analogy though, is that we in primary care we have a lot of conversations about vaccinations. And and it is often in the news, and quite rightly so. And so then we are used to answering these kinds of questions and dealing with these kinds of queries all the time that are precipitated by something being in the news or television or whatever. We're used to dealing with that. I would welcome it, and I do welcome it if anybody wants to ask at any time. And I find that bringing it back to me, I don't want it to be about me, because I am one person who is part of a great team, and but it's about having somebody sometimes who is the face, the voice of something, isn't it? And it can be that in anybody's area. Everybody here today, whoever you work all over the world, I can see that. And but I've been to India and seen great things with nurses in India, fantastic care being given, and also a huge amount of enthusiasm. So that can apply to anything, can't it? In any area. You've just got to get out there and bang the drum for it, really, I think.
Do. I mean, so moving on slightly now about service pressures and opportunities. I mean, Sarah, what are you finding that your service in tissue viability now is massively overwhelmed with legs?
Yes and no. I think we do see a lot of legs, and we do see a lot of patients maybe presenting to hospital and being admitted to hospital, whereby yes, they may, that may be their reason for admission. For example, if they've got cellulitis, or it may not be their reason for admission, but, they present, whenever they present within the hospital system, somebody will see a bandage on their leg, and it's like, okay, let's refer to tissue viability. And there's even a fear of taking the bandage off.
Yes.
They don't want to do that. And I think, that then creates pressures, because if we were facilitating those frontline clinicians to be able to just have the confidence to put on something simple, and to recognize maybe what type of wound they're dealing with, then that we could sort of streamline the appropriate referrals from the unnecessary ones, really. So yeah, I think there's so many, we see a lot of patients in the acute setting. It's very difficult to manage patients with lower limb conditions in the acute setting. And there's usually non-use of compression in that setting, because we don't have nurses and practitioners who are trained up to be able to apply that. So that then puts potential pressure again on services like tissue viability, like vascular, but we're not able to provide the treatment and the interventions that we would like to do. And we're not able to go and see every patient with a leg wound in the hospital to sort their compression out for them, so such a difficult thing. And finally, sort of thinking about pressures on services, I think I see somebody in the chat has written this, and this is one of my big things. We need earlier education within the health systems to be able to help people within nursing and medical undergraduate training. There just needs to be better wound care, because we see it all the time. We mentioned around sort of preventing cellulitis for patients with low limb wound conditions. It's one of my big passions, is the overtreatment of or misdiagnosis of cellulitis in hospitals and within GP practices as well. In this era of antimicrobial stewardship, I think we're doing a very poor job in that respect, in as much as It's great for us. We get referred to go and see a patient with cellulitis. By the time we go and see them, they're on a hospital ward. They've already been commenced on industrial strength IV antibiotics. And we're not able to have a discussion with them, with the prescribing clinician, about were they actually appropriate, or was there actually a different condition going on. So I really do think it's important to teach our doctors as well as our nurses very early on about these conditions. But like I say, they're just not sexy enough.
No.
Yeah, and but if we could hopefully streamline our services better, and that would reduce demand on so many of us in very different ways.
Do you think?
And if we had joined up care as well?
Yes, I would agree with that. I was just going to say there's a place for more joined up care. But the other thing is that obviously when patients do go into hospital, and you've done so much good work in the community, getting their legs to an absolutely brilliant stage, and then unfortunately come down with something that's probably unrelated to their leg, they're admitted, off comes their compression because we have to look at the leg, and nothing goes back on. And then, of course, they go right back to square one again. How do we encourage those patients then to be more able to self-care? Now, I know of a team in Liverpool, and they give everybody that comes in with compression a wrap.
Yeah.
And I thought that's really good. But then obviously there's an expense around that. And maybe not every health board would be prepared to do that. And there is another brilliant service in Bristol where they were able to look at their data about patients that come in with leg ulceration, and they have been able to fund an entire team that provides compression bandaging just for those patients that have come into hospital. And it is brilliant.
Yeah,
But then we haven't all got the funding to be able to do that type of service. So I don't know, is there a place for encouraging those patients to be more interested in self-care and asking those questions when they go into hospital? Well, what are you going to do about compression?
I think that the patients themselves, particularly if they've been in compression for a certain period of time and have become accustomed to that, or alternatively have had compression previously. We all have these patients who re-ulcerate despite everybody's best care and best intentions. And so these are really knowledgeable patients, and it can be quite frustrating. And I absolutely understand the limitations of secondary care and having to have, people who, staff members who could apply compression. But it is quite dispiriting when, as you say, your patient goes into hospital for something else, and you think, oh God, they were nearly healed, and then they just go back to stage one again. The only thing that is a benefit sometimes is that they're spending a lot more time in bed with their legs up. So so sometimes you do see the benefits of that, to be fair. And they're getting those kinds of things dealt with, and also perhaps many other things that need dealing with. But I do sometimes think about whether patients that we think actually, you have multiple admissions, and we know that, and a lot of the work that we do with them is avoiding those admissions for them in primary care. And so we do a lot of work with our GPs so that we can try and avoid admissions, basically. But maybe these patients need to have a wrap that they take, they're right, okay, if I get admitted again, I've got this wrap and I'm just going to take it to the hospital with me. And maybe those kinds of patients who end up going into hospital multiple times, that would be a really sensible thing, that they have the knowledge. The patients have the knowledge, they really do.
We need to create an environment as well whereby we facilitate them using that knowledge, because and I completely understand, maybe nurses on a stroke ward may not be aware of all the different types of compression. They don't know what it does. It doesn't make any sense to them. And then you've got a patient who pulls out a wrap or a stocking and goes, right, nurse, I'm going to put this on my leg. And they go, oh, well, I don't know what that is, what it's going to do. And we don't really, and so they go, oh, just hold off on that now. And I mean, I've got the answers to all of this. Like I say, we really do need to think outside the box, but we do need to facilitate an environment in the secondary care, particularly, whereby we can allow patients to self-manage and not be fearful of potentially coming to harm just because they're in hospital.
In the same way, they go into hospital, don't they? And they are asked to take in their own medication.
Yes.
So it's just a medication. And I do wonder, so we get wound care plans from the hospital, from secondary care, and we follow those care plans unless we think actually that needs a change or whatever. It depends where that's come from. Maybe if it's from vascular and it's a specific plan, or if we're doing shared care, then we will continue to follow that plan. But in the same way that we would follow a secondary care plan, why couldn't they follow a primary care plan that we've sent in with them? And I know there's a lot of work in industry about educating patients. And so we can give them, various booklets. Lots of the companies have things about venous disease and about understanding more about that. And also there's new booklets from lots of the companies coming out about providing a care plan, so that they have a care plan that they can carry around with them, and they can say, right, I'll take my care plan in with me to secondary care, and we can say, right, they're having compression at this level, and that could be followed in the same way that we follow secondary care planning. But again, it's a bit more joined up thinking, isn't it? It doesn't. And everywhere in the UK, I don't know about in other countries, I'd be interested to know, does everywhere do everything different like we do here?
Probably.
Because, it's, that's a frustration, isn't it, for all of us?
Definitely, I would agree with that. So we're coming up to almost a close of play now for us, but I'm just thinking, we've talked about prevention for those patients, and how we know that harm is often avoidable as well, and maybe some strategies around preventing patients coming to harm. We know that early action definitely is the game changer with these patients, and we need to try and get in as early as we can so that they've got better outcomes and they don't deteriorate to that level where they even need to get to a specialist service. If this is achievable in community, then all the better. I mean, I could probably wander around town centre and I could look at patients' legs, or people's legs rather, and think, I could just tap them on the back of the shoulder.
Yeah.
Let me just give you some stockings. But that's because we become attuned to looking at patients' legs all the time, don't we? And that's it. And we notice it in people. And I see people with varicose veins, and I think, have you been to your GP? Maybe you could get a referral to vascular to get those sorted out. But then it's about that early action then, and preventing more pressures on the service. If there was one thing that you would encourage people to do differently, or that you would do differently following this session, what would it be? It's a tough question.
To talk to patients, ask them what they think the problem is, and try and help them with that. And try to get them to understand that compression is not the evil that they have been taught it has been in the past. And it's not the awful thing. And also to as part of that, just help them to understand about helping themselves for the future as well. Compression is not evil. And clinicians will listen to you and help you. Sorry, just to just add in another thing, I'd love to have a stall in the local supermarket.
Do it, Kath. I think you should. Definitely. You could drum up a lot of trade. What would be your thing, Sarah?
I think sort of following on maybe from a similar theme to Kath, but from a healthcare professional, perspective, it's about how we reduce that fear of compression. And I do think sort of early education is so important in that sort of process then of being able to implement early, so these kinds of interventions, and not be fearful of them. So yeah, that would be me.
Yeah, definitely. My one thing is obviously, as a vascular nurse, if you do have any patients that you have venous disease, venous changes, get them referred to vascular early so that we can see these patients and see whether or not they're suitable for any endovenous ablation or foam sclerotherapy, because we know we have the evidence to support that in conjunction with compression will help to heal these patients. And if we could get them early, we can prevent them turning into ulcers and improve their outcomes phenomenally. Well, I've had a really great time this afternoon chatting to you both. It's been really good, really interesting. I just need to say that Sigvaris team, they are available, and please feel free to reach out to them if you'd like some support within your area. They're more than helpful and would be willing to come and help you out. There's also loads of information on the website as well that you can use for your patients, information leaflets. Similarly, we have on the Legs Matter website as well, and Society of Tissue Viability also hosts that as well. Well, thank you, ladies. I've had a brilliant afternoon and it's been really enlightening. I hope everybody that has joined has enjoyed the conversation just as much as we have.